Hey everyone, welcome to the Optispan podcast. So today I am joined by Dr. Kim Celmer from the Institute for Complementary Medicine. Super excited to have you here, Kim. Thank you for coming down to Optispan HQ. And so one of the first questions that I want to give you a chance to address is you are a doctor of naturopathy, and I think it would be useful just to kind of set the stage for, what is a doctor of naturopathy? How does that maybe differ from a sort of traditional MD or primary care in what you do? And what are maybe some of the preconceived notions that you've come across that people have that are incorrect or maybe not quite right?
Usually what I start with is, we're trained in the basic core medical school sciences, very similar to how a family practice doctor is trained. The difference, though, is we study a lot more alternative approaches to health and wellness and disease. So we utilize a lot more vitamins, minerals, herbs, a lot of lifestyle and dietary counseling as well. And I think one of the bigger differences is we spend a lot more time with patients, figuring things out with them. But we utilize all the standard lab testing. Sometimes we do more specialized lab testing that's looks a little deeper at things, not your classic, pathology-based labs. And I think one of the bigger things, we can and do prescribe medications.
Yeah.
We have prescription authority, and we do prescribe medications when appropriate and necessary, but that's not usually our first
Not the
reach.
first line of defense.
Yeah,
so to
usually
speak.
we're working towards that. Sometimes medications are appropriate alongside what we're doing, but we're really trying to understand what's unique about that person's individual situation and really trying to identify obstacles if we can to getting them better, and removing those if possible, trying to find, this whole term root cause. Sometimes you can go into a rabbit hole trying to find that, but we try to do that as much as possible.
So I think one of the misconceptions is that you only use natural remedies, right? And so you've already sort of addressed that, that may be where you start when possible, but certainly will utilize what more people would think of as traditional medicine or pharmaceuticals when appropriate.
And our typical first visit with a patient is usually an hour. Sometimes it's a little
compared
longer.
to 5 minutes with your primary care
Exactly.
doc.
Yeah. So we spend a lot more time really looking at the whole landscape to really kind of figure out, okay, where do we go with this?
And one of the things that we think about a lot is this, what I would say is it should be a necessary shift from reaction to being a bit more proactive, preventative. Is that something that you incorporate into your practice?
Definitely preventative. I mean, obviously we have people coming to see us who are otherwise healthy and want to maintain that. We tend to also see a lot of people who are kind of at the end of what they can get through what we call allopathic medicine, where they're, it's sort of like the frustrating, all your labs are normal, like the frustratingly normal results, right? But why do I still feel this way if they can't find out what's wrong with me? And so that's really where we step in and we dig a lot deeper and figure out, okay, what might this be?
And can you give us a feel for some of in your experience, what are some of the causes of that? So again, I think if I understood you correctly, what you're referring to is a patient will come in, they've got symptoms, right? Fatigue, chronic pain, depression, whatever. But all of the basic lab tests look normal. So where do you, I mean, obviously it's going to depend on what the symptoms are, but what are some of the common things that you come across in that realm?
Kind of our bread and butter for most naturopathic physicians is digestive disruption. I mean, irritable bowel syndrome. And, that's really just a diagnosis. Well, you don't have a colon cancer, you don't have ulcerative colitis or any of these, bowel diseases that are real diagnosable. So you've got some sort of functional bowel disorder, take fiber, or whatever. They're just given advice to either take antidiarrheals or medications like that. So that's one thing where we really dive in more deeply. We're looking more at food sensitivities, not necessarily food allergies. And I keep that word very specific because there's a real difference between that.
Sure.
And it can be a little bit tricky to figure out with patients.
And just for people who may not know the difference, what is the difference?
Yeah, I mean, an allergy is a true allergic reaction that's involving the immune system and, often histamine response. And someone's truly allergic. Most people will often know they're allergic to a food because they eat a raspberry or strawberries mainly and their lips swell up or something like that. They really truly know there's a food allergy or those really more severe anaphylactic allergies where someone's, going to potentially die if they eat peanuts.
Right.
But sensitivities are where someone eats a food and they definitely feel unwell, but it's not testable by an allergy test.
Right. You can't find an immune response to that
thing. There's other mechanisms involved, some sort of inflammatory response or some sort of something that you can't really test for. Yeah.
And let me ask you, because I've heard researchers who I know in the field who talk a lot about how some of the inflammatory response to foods are actually being driven by how much of our diets today are artificial or processed. And so our bodies are experiencing molecules in the food that aren't part of what we've evolved to experience. And so it may not be a true allergic response, but it does induce either a change in the microbiome or some other inflammatory response to these molecules that we, from an evolutionary perspective, have never seen before.
Could be that. It could be this concept of just general, I guess, inflammatory response to the gut, where people talk about leaky gut, where those tight junctions are a little more open. So sometimes I'll see people who are sensitive to so many foods. I'm like, that can't really be real. I mean, it can't be that you're that allergic to that.
There's something else
going on with your gut.
Yeah.
So if we can work on the gut, we'll probably find those couple little things that you're truly sensitive to. And I guess I didn't really answer your question, but it's more about, immune responses to not only things that the immune system doesn't really recognize. So what is it going to do? Mount a response of some sort, which is usually inflammatory. But that can, I think, happen with foods if there is an ability for a molecule that's too large, that should not be getting through the gut barrier, because it's not fully digested down to the molecular size that it's a nutrient. So then that's getting through because the gut is allowing that.
Right.
And then there's an immune response there. So there's actually a food reaction, but it may not be a real reaction to that food. If the gut is healed, then they'll actually maybe not react to that food.
Right. Or I would imagine if you have leaky gut, that there are probably also bacterial components that can leak through at the same time.
Absolutely. Yeah. And those lipopolysaccharides and those things that are pretty toxic.
And so this is, I mean, leaky gut is something that, again, scientists who study aging biology have thought about, and certainly there's an age-related component to leaky gut. In other words, as we get older, we're more likely to experience this, and that's true. Even in simple animals like nematode worms, which the guys next door study, right? This happens, that you get a loss of the gut barrier, and so you start to get molecules escaping the intestine that would normally be kept there. But I think the mechanisms are maybe not quite so well appreciated. I guess what I'm wondering is, in people, in your experience, what are some of the factors that would predispose somebody to leaky gut, or that can contribute to that? And then what are the therapeutic strategies you employ to do
what do we do, and how does it occur? Certainly antibiotic use, which then disrupts the microbiome, which then, disrupts, the gut barrier.
So antibiotic use can be a cause of leaky gut.
Frequent, frequent or, multiple courses of antibiotics.
Okay.
Definitely. Because what's going on is your microbiome is keeping the lining of the gut healthy through those short chain fatty acids it's creating. And if that becomes disrupted, you're going to, probably have less support to the gut lining, and there you are.
So before we go on and talk about other causes, I think a really important question is because sometimes we can't control when we have to take antibiotics.
Of course,
So what can somebody do if you need to take antibiotics to reduce the risk that you're going to have these downstream negative consequences to the microbiome and the gut and so forth?
My favorite thing to recommend is a prebiotic yeast called Saccharomyces boulardii. It does not colonize in the gut, but it stays there while you're taking it, and it seems to protect your microbiome from the antibiotic. And because it's a yeast,
so when you say protect the microbiome, you mean you don't get the negative changes as a consequence of the antibiotic?
Yeah. Basically, I mean, I kind of envision it like it's creating this little kind of foamy layer over your bacteria, so that the antibiotic can't really get to that microbiome. That's not
I
really
see.
how it works, but I kind of envision it
Yeah,
that way.
sure.
Because and you can take it at the same time you're taking the antibiotic, because it won't kill it. It's not a bacteria. So some
Right.
people take probiotics, and I'm like, I don't know if that's going to really work for you, because you're taking an antibiotic at the same time
Right.
you're taking a bacteria.
Right. And so just to be clear, I know what you're saying,
Yeah.
but maybe not everybody appreciates. Because it's a fungal species, it's not a bacteria. Most of the antibiotics that people get prescribed are antibacterials. It's not going to affect the fungal species that you would take as the probiotic.
Right. And it seems odd to take a fungus when we're like, we don't want to be infected, but it does not stay. It's interesting.
Right.
Yeah.
So it doesn't colonize the gut, but it just kind of gives a sort of transient protection to some extent.
Yeah. And I think, from what I understand, if you're in Europe and you're given an antibiotic prescription,
oh, interesting. It's just always something they
just
couple
give it
with
to you right there.
Okay,
Yeah.
cool. So what was the name of that again?
It's called Saccharomyces boulardii. People call it Sacro B.
Okay.
And there's a specific product, I think, that was.
We'll link to it in the show notes for people who are interested. But I think this may be a topic that we should do a deeper dive on as well. So very cool.
We could, yeah.
Okay, so that's one thing people can do if you have to take antibiotics.
Certainly, if you do have food sensitivities to begin with, whatever, you could make that worse by eating those foods over and over again and irritating the gut. Alcohol, it's a solvent. It's a solvent on the gut, so that's going to be irritating to the gut.
Right.
Stress, we all know that stress affects gut health. So those are some of the big things
that can contribute to gut irritation and leaky gut to some extent, and then the downstream consequences of that.
We talk about post-infectious IBS. Let's say you had food poisoning or some sort of infection. You can have a condition that's called post-infectious irritable bowel syndrome from a prior infection. So that's another thing too.
Right. Interesting.
So many people have digestive issues, look at all the antacid medications and all the things that are, advertised for.
Yeah. What are your thoughts about common use or daily use of over-the-counter antacids? I know there's, we've heard horror stories, and then some other people will say, it's not a big deal. What's your thinking there?
I think there's different levels of problems, or different levels of meds that can cause problems. Obviously, the most commonly used antacid is a proton pump inhibitor. Yep. That's your omeprazole or Prilosec over-the-counter product. And I think that's probably the more problematic long-term use. There's some links to potential, cardiac issues or absorption of nutrients like minerals and that, and maybe bone health. Mm-hmm. I did hear one research talking about PPIs being problematic for the production of nitric oxide. So, and there's, that's for vascular health. Right. So I don't know the data on that, but I thought that was interesting.
Yeah.
I think the lesser of those are what we call the H2 blockers. Pepsid AC, I think, is the most, or famotidine is the one over there. I think that's a little bit, if you have to take one of these things, because I talk to my patients about like heartburn and dyspepsia, is it functional? Is it that there's a difficulty in however the stomach is functioning that we can actually correct? To correct that, is it a food, do we need to correct functionality? Yeah. Or is there a structural thing going on, like a hiatal hernia or something going on with the lower esophageal sphincter that's it? And they don't really do a lot of surgeries for that because it's not a really great surgery unless things are severe. So you have to kind of try to figure out, can we correct this or do we have to manage this?
Right.
And if you're not well managed with heartburn or, reflux,
right,
you can really irritate that esophagus in a way that you could potentially, get a precancerous condition in the esophagus. So talking about those meds, I really try to get people off of the proton pump inhibitors if possible by maybe transitioning to the H2 blocker. And if we can be there and manage, a structural issue that way, I like that better. It doesn't seem to have as many problems with absorption of nutrients.
Okay.
So, yeah.
And I mean, I would guess some of the same potential causal factors that we already talked about are contributing to, chronic heartburn, alcohol consumption,
smoking, all these things. But one of the concepts that we really use a lot, or I guess, I don't know if it's a concept, is it a theory? Maybe a theory that we go by in naturopathic medicine is that we think about, okay, how does the stomach allow stuff to go down, but also prevent stuff from coming up, right?
Mm-hmm.
So you have this sphincter at the bottom of the esophagus, top of the stomach, that's controlling that. If that is staying lax or open, then acid or contents of the stomach can potentially come up. We're assuming there's not, the stomach's not slipping up into a hiatal hernia or something like that. So we have that. What influences that sphincter to tighten and relax? So we know that alcohol, spicy foods, cigarette smoking, strong spices,
Coffee.
Coffee.
I didn't want to hear that.
But not everybody. People
Yeah.
can drink coffee all day long and not have reflux. But people who are susceptible, that's it. But also, the level of acid in the stomach influences that.
Yeah.
So, and it's so expensive cellularly to make stomach acid. The cellular currency it takes for the body to do that is a lot.
Yeah.
So it doesn't make sense that people as they age are going to start making too much acid.
Right.
And it's going to start going up in their esophagus. Usually they're making less.
Right.
And when that's kind of suboptimal, that sphincter can stay more relaxed. So let's just take a medication to lower it even further so that at least we won't get stuff coming up and burning the esophagus. So part of how we approach it is we say, can we figure that out? There's some tests that you can do, but sometimes we just do the little simple, let's actually give you hydrochloric acid with your meals and see if you can tolerate it. If you can tolerate taking more acid, it's probably the case that it's probably kind of low. And if we can restore your stomach acid to more optimal levels, does that allow or cause or influence the sphincter to tighten back down again?
Yeah.
And thereby, we've just corrected the issue.
So it's really interesting. So so it's counterintuitive, right, to the way
Completely.
you would think about it, is that it's actually potentially a failure to maintain enough acid in the stomach that's leading to the reflux or contributing to the reflux and inducing heartburn.
Yeah.
Okay. Interesting.
Yeah.
So
So we restore that.
Yeah.
And you can, in many cases, resolve the reflux.
And how do you restore it? Once you've done this diagnosis, what are the steps to restore it?
The term is hypochlorhydria, meaning you having lower acid than you should, or achlorhydria, where you just don't make stomach acid anymore. And some people develop that. I don't know if it's an autoimmune thing, or it probably is to some degree. So the question is what? So how do you do that? What we tend to find is if we start restoring stomach acid, we're giving it. We're giving it in little capsules with meals.
Right.
And as long as it's not causing any pain or heartburn, we kind of figure out, okay, what is the amount that we have you take? And what we start to discover is it's almost corrective in a way, and I'm not exactly sure how that works, because over time, maybe over several months, someone's like, ooh, I can't take that much anymore. It's way too much. Maybe they're on 2 capsules. Now they're down to 1 capsule.
Right.
And then maybe they're down only to 1 capsule with their heavier meals.
Right.
And then they're really not taking it much at all.
So this is really interesting. And I think what you described, we see in other areas sometimes with aging, like I think with the immune system, there's a decline in immune function in some ways, but that's because you're having inappropriate response in other ways. If you can rebalance that with maybe an appropriate anti-inflammatory, the system sort of resets itself and you don't need to keep using that whatever therapeutic to rebalance the immune system. It might be something similar that's happening here.
It could be. And maybe you restore it to a time where, someone's not taking this hydrochloric acid anymore, but eventually, if aging continues, is it going to kind of come back down again and you have to maybe support periodically?
Right.
And that is possible.
Cool. So I'd never heard of this therapy before. So that's really interesting to me. And I think
done it for years.
Yeah.
Yeah. There is a test. There are some tests to test stomach acid. I think it's called the Heidelberg test. And some people really want to know, and they swallow this capsule and they do these challenges where they
Right.
challenge with bicarb to
Right.
see how well can the stomach actually respond. And there's some ways in which they can test that. But I just do the simple test. Say,
I
hey,
mean, if
take
it
this with your
works,
meals. If it
it's
causes heartburn, we're on the wrong track.
yeah.
If it doesn't, how much can you tolerate?
Okay.
Yeah.
Cool. So I learned something
Yeah.
new
Hydrochloric
and
acid trial.
valuable. Yeah. Awesome.
Old test. Yeah.
So gut issues are one of the
Mhm.
major sorts of things that you see a lot of. What
Most
else
naturopaths do.
is
Yeah.
pretty common in your experience?
Well, fatigue. Fatigue is a big one, and that can be so many factors.
Sure.
Nutritional insufficiencies, maybe not deficiencies, but maybe true deficiencies. Certainly, that can lead to all sorts of different
What are the common
problems.
nutritional insufficiencies or deficiencies that you look for?
Well, D is a big one.
Yeah, vitamin D.
Your classic D and iron and things like that, that you can test in a classic
Yeah.
blood test.
And in the Pacific Northwest, as we know, most of us are walking around with at least insufficiency in vitamin D.
Yeah. And there's then, how do we define that? Because there's some labs that, are much conservative, some are not.
I mean, I'm interested in your thoughts. Like, where do
Mhm.
you land? Where do you want to see your patients with respect to vitamin D?
Yeah. So I usually go with the classic, like large, LabCorp Quest type reference ranges, which is 30 to 100. I don't know if that
Is normal.
is a typical reference range,
Yeah.
I think Kaiser is 20 to 80 or something like that. So when you're below that, obviously the number one thing is compromised your ability to absorb calcium from your diet, which is important for so many things.
Yeah.
But so when you're deficient, that's like the primary problem, not to mention how much it affects immune function and all that. So sufficient is 30. Optimal, I like 50 to 70.
Yeah.
And I think there's a little bit of data to support that. There's some associations between lower incidence of things like breast cancer, colon cancer,
Right.
MS, things like that when those numbers are.
Right. Yeah, that aligns pretty well, I think, with what I've seen, and the epidemiology backs up 50 to 70 or 80 as being optimal for a lot of stuff.
Yeah, sometimes, 80 is fine.
What do you think about because there seems like there's a growing, I don't know if it's growing, there's a vocal, at least on the internet, set of people who say that supplementing with vitamin D does nothing and is actually harmful.
I don't know if I agree. I don't know the data on that. I think that if you can create enough vitamin D, that's optimal.
Sure.
Right?
If you don't need to supplement, you're getting it from sunlight or the little bit that you can get from diet, right?
Right. So then my next question is then if your vitamin D is 7 or 8, what are you at risk of?
Yeah.
How is that treated? I mean, rickets, how do you treat that then?
Right.
You give vitamin D.
I agree. I mean, I think I think that's a valid question, I guess. And I mean, I think certainly if somebody is below the lower cutoff for deficiency, supplement up.
Of course. So you're talking about like if you optimize.
Well, this is where I think that the rhetoric gets. I don't know what these people are actually saying. I know how it comes off, which is that nobody should supplement with vitamin D, which I think almost anybody would say that's ridiculous. But if, and then the question is, I guess in my mind, I don't know the answer either. That's why I'm asking. Right. But in my mind, when you get into, let's say somebody's at 32, right? Mm-hmm. And, we both think that 50 would be better. Mm-hmm. What's the risk reward for supplementation there? Again, I've seen some of the data. I'm not convinced that there's any significant risk within a reasonable range, but there are people out there who are very vocal, making a lot of claims and that scaring there's actual people. Risk? Yeah, that you shouldn't supplement with vitamin D and that it increases, risk. I don't know what. I just want to, I want to see, I've yet to come across anybody whose opinion I respect who feels that way, but I like to ask because maybe I'm missing something.
I don't know where that's coming from. Like, why is vitamin D so scary? Because it's a fat soluble vitamin. And yes, obviously any fat soluble vitamin you can, have a problem with if you really take too much.
Because it'll take a while to get out of the system. It's not like something. It's not like
Right.
vitamin C where you take it, you can measure it immediately, and then
right.
you'll pee it
It
out.
can build up. It
Yeah.
can build up. So
Yeah, and I think that's a different question, and it's good that you bring that up because it is worth people knowing that if you start taking a vitamin D supplement and you go get a blood test the next week, you won't see anything.
No.
So don't start taking 4 times as much thinking you're not getting enough, because you can end up taking too much.
Yeah,
but I think that's completely different.
I usually give about 3 months. Like if we're gonna supplement and we want to see that number change, I really won't test it again for at least 3 months to see what is that, and then where do we go with maintenance?
Yeah.
Are we continuing to build up? But I think you've got to be pretty high on those D levels to really see toxic effects.
Oh yeah, I mean, my guess is you got to be over 100 probably to really see significant problems. And most people, again, everybody's different, but
yeah. I mean, and I think, I don't know, but I think to actually have the toxic effect, I mean, certainly 100 is the high limit, but I think for toxic effects, true toxic effects, I think you're well over 100.
Yeah.
It's just we don't like to really see people.
You don't want to push it that far.
Right. So it takes a bit of work, but I have had some patients mistake or misread instructions and take 10 times their dose every day. And like, oh my gosh, let's test you. They get, a little bit over 100. We just back them off.
Well, I'll make an admission. I did get up to 106 one time because I was impatient. And I just backed.
Yeah.
But I didn't have any problems.
Yeah. And it can be done, but I'm not sure where they're saying the harm is.
Honestly, I think part of it is a backlash.
Yeah.
So I mean, as I'm sure you appreciate, right? There is a culture of conservatism among much of the medical community. And I think part of the backlash is that vitamin D supplementation was being marketed so extensively that there was a pendulum swing too far the other direction to nobody should be taking vitamin D supplements in some people's minds. And I think it's just this hyper conservative mentality pushing back against, that's my guess.
Probably.
Yeah.
And then there's, I don't know if you call it clickbait, but if
there's some of that.
Scary,
how do you get clicks on YouTube? Yeah.
Right.
Scare people. Yeah. So vitamin D is one.
Yep.
Other major nutrients that you would typically want all or most of your patients to be thinking about, test for, aware of.
Yeah. I have my basic 3. So, and that's going to be, especially where we live, supplementing with omega-3 fatty acids, whether it be dietary, if they can get it in their diet, if not supplementing.
Good sources in diet?
Fish, fatty fish.
Yeah.
Mainly.
That's the big one.
So there's your omega-3s that are marine-based ones, and I'll explain why I kind of prefer those a little bit, and then there's your plant-based ones.
Okay.
So that, that's going to be fatty fish and things like that. But the plant-based ones are going to be, like walnuts, walnut oil, chia seeds, flax seeds, hemp seeds. You're going to get omega-3 fats there too. So that's one. And I can come back to the differences there between the plant and the marine oils.
And can you tell the difference on the blood test?
Yes. Yeah. There are, there's actually a commercially available test. Quest, I believe, is who does it.
Omega Check.
Omega
That's
Check.
what we
so
use,
you can see those. I use another lab called Boston Heart, and they do one that I'm a little bit just more used to looking at the format, and they'll do saturated fatty acids, they'll do trans fats, they'll do, then they'll do your EPA, DHA, and ALA.
Right.
And then they'll do the ratio of arachidonic acid to EPA and some of those things. Yeah.
So there's vitamin D, omega-3.
Omega-3 fatty acids, just because we just don't get that many in our diet, like we, compared to like omega-6 fatty acids. We want to keep that balance.
Right. And particularly in the United States, right?
I think
there are parts of the world where, the dietary consumption of omega fatty acids is quite different.
It's much better, yeah.
And I think I saw somewhere that I think it was South Korea, the omega index is like above 10 for the population. So, whereas here, I think it's below 3 if you just look across the population.
Probably, yeah. Yeah. So that, and then actually just a basic multivitamin. Just a basic multi. I mean, there's now some actually a little bit of newer data, I think, on older adults and, reduction of dementia and that sort of thing. Finally, after.
Do you have a favorite multi?
Not really. I mean, I have a couple that I recommend, and I actually don't even recommend people take the full dose.
Interesting.
I just say, just to bridge that gap between supply and demand, just a little bit. If you have a relatively healthy diet, what we're trying to do is just account for degradation in foods as they travel, and sit on the grocery store shelf. Probably higher demand just living in this environment, just to kind of bridge that. If I feel like someone's really depleted, I'll say take the full dose.
Yeah.
But I think just to bridge that gap.
Yeah.
I think those are your core three things.
I think it's interesting how much variation in opinion there is on multivitamins, just among the wellness longevity community, which obviously encapsulates a lot of different people.
Right.
But I guess my personal opinion, I've never felt that strongly one way or the other, honestly.
Yeah.
But I have gravitated towards just take it as an insurance policy, right?
Right.
Because it's very unlikely that it's going to cause any significant harm unless you're mega dosing or whatever.
Right.
And if you're deficient, get it taken care of. And
Yeah.
some of these things we're not going to measure, or we can't measure very precisely.
Mhm.
So, and with age, as you said, absorption generally goes down,
Mhm.
the higher likelihood of deficiency.
Right.
So,
And, I think the most recent study that was done, I think, on dementia and multis that
Yeah.
was pretty widely publicized, I think it was done on just Centrum Silver.
Yeah,
and that's
that's right.
why I say I'm not too snobby about
right.
the type per se, but I think there's obviously better products out there than others. And
it's probably like anything
know.
else, especially when you're talking about supplements, going for the very, very lowest priced thing you can get is probably not the way to go.
Well,
but you also don't
yeah.
need to go for the very, very highest priced supplement.
Here's my saying. The most expensive supplement is the one that doesn't really have what it says on the label, right? So that's going to be or that doesn't do what it says on the label.
Yeah.
So that's going to be the most, even if it costs you nothing, it's not doing what you want it to do.
Right.
So I think, and this is where we come into the whole issue with, quality and what's in the product and, adulteration of supplements.
And the supplement industry is just, it's really difficult to navigate. So I think the probably the best advice is just to find a reputable brand that's been around for a while, that does third-party testing.
Right.
That's not at the very highest end or very lowest end of the spectrum in terms of cost.
Yeah, and there are some pretty good over-the-counter brands, and some of those brands are owned by like the German pharmaceutical companies, and they're created in pharmaceutical type facilities, and they are tested in those ways. So there's some good stuff out there that you can find on your regular, health food store shelf, or even your drugstore shelf.
So D, omega,
and a multi.
I
mean, that's kind of your basic.
Yep. I take all three of those, and that's pretty much all I take, honestly, in terms of supplements.
The only other one that we just, the minerals that we think about, calcium is a big thing, I think we don't want to over supplement with it. Make sure you're getting enough in your diet. But magnesium, I think
magnesium,
even more
I was
so.
going to ask you about. And
magnesium,
is that something you think everybody should take?
I think it is probably a good idea, because the amount of magnesium that most people get in their diet is probably less than even calcium. And so supplementing with a little bit of magnesium is probably not a bad idea.
Yeah. I took magnesium for a while, and I just recently stopped because I felt like I was having some gastrointestinal upset, which is something that happens if you take too much.
Well, yeah.
So maybe
it's the notorious laxative. Milk of magnesia.
Right.
Right. Or all the colonoscopy prep is magnesium citrate.
Right.
So actually, depending on the type of magnesium you're taking, you can either avoid that or use it for that purpose.
I was going to ask, do you have a type of magnesium that you typically would recommend to your patients?
Depends on what I'm using it for. So if it's a general just magnesium supplementation because we feel we want to have that, I usually will lean maybe towards magnesium glycinate, just because it has a little bit of nice effect on the brain and may help with sleep. If we're trying to also maybe manage a little bit of slow gut function, we'll stick with citrate. If there's more sort of mood stuff, anxiety stuff, I might even lean towards something called magnesium threonate, which has, Magtine, which is the trademark product, which can be really helpful for deep sleep and other things like that.
So it kind of depends on the person's situation. It kind of depends,
but I think if you're run of the mill, I think, mag glycinate, some of the products kind of have a combination of a few, which is fine. A few different, types of magnesium.
Yeah. Right. Okay.